Thank you very much, Dr. Okay, thank you very much, Dr. Brewster. I'm very pleased to be able to speak to you all about the urgent need for cross-cutting anti-racist approaches to cancer disparities research. Similar to Dr. Mantle, I'll be scoping out a little bit from the topic of cervical cancer specifically to ask us to question and reframe how we think about approaching the health and the cancer outcomes for marginalized women. These are my disclosures, funding sources for research, not relevant to my talk today. So we have seen these graphs. They've been provided by the wonderful organizers of this event. Disparities in cervical cancer mortality by race and ethnicity are unacceptable in this country. We have stagnant cervical cancer survival rates, and we must acknowledge that we also have unacceptable disparities and poor outcomes among Black women, Latinx women, and Native American, American Indian, and Alaska Native women. I'd also like us to remember that in addition to cervical cancer, we have endometrial cancer disparities in this country. Endometrial cancer is 4 times as common as cervical cancer, and it is one of the only cancers in the United States that continues to increase rather than decrease in incidence. And despite the fact that the burden of endometrial cancer is similar among Black and white women in this country, the mortality is starkly different. Black women in the United States have an over 90% higher 5-year mortality after a diagnosis of endometrial cancer compared to white women and all other groups of women. I would invite us to understand and to reflect and to move forward with the fact that these racial disparities in cancer outcomes are not a surprise. They are the default outcome of our current biomedical research and healthcare delivery system. And I pull on frameworks and scholarship many years in the making from medical sociology, gender studies, race studies, and the studies of our healthcare system, one of which is the fundamental cause theory that explains the enduring link between race, socioeconomic status, and other social factors, and health-related mortality in general and cancer-related mortality specifically. This link endures regardless of innovation, regardless of the advances that we make in clinical trial discovery, because of because of differential access to key flexible resources in our society: knowledge, money, power, prestige, and social connections. These are assets that operate via our structures of biomedical research and innovation. And because of this enduring link, differences in outcomes, in health outcomes that are based on social position in a society, we will see them. They will always arise in the context of the treatability of a given condition. When we move forward with our research to make a certain disease site a cancer treatable, we move forward with exacerbating disparities in our default system as it stands. I'm going to walk through this. Phase 1 of this paradigm that is reproducible across different contexts, across different countries, across different social groups, across different diseases, is that before we know a lot about how to understand and treat and intervene on a disease, we have what we call natural inequalities, very small differences between groups because we have limited knowledge about risk factors or limited effective treatment, and overall the mortality rate of that condition is stable. When we move on to innovation and we're able to intervene on various diseases, we see an unequal diffusion of those innovations, of risk factor reduction and treatment strategies. So we see an overall decreasing mortality rate with increasing disparities in marginalized populations. What we then try to do, and what happens in the event of the default mode, is that we then move into reducing inequalities, or we hope to, where we then create adaptations and we increase access to this new knowledge and innovation, sometimes creating new knowledge that was missed the first time around. And we have decreasing mortality rate with decreasing disparities. And where we all want to get to is reduced mortality, minimal or absent disparities, widely available prevention, and effective treatment. This is how we move through biomedical research, discovery, and intervention to improve health right now in our society. Treatability increases because of federally funded biomedical research. I never want to minimize the contribution of scientific discovery because it is so critical. It gets us to the point where we're able to decrease mortality rates. It is in many ways these NIH-led discoveries of innovations, risk factors, and treatments that get us to this point. However, the default is that we do this without an equity lens. We have a tolerance of predominantly white trial participants being sufficient as quality evidence that something works well across all populations. We do not routinely include equity science expertise when designing trials or developing new biomedical interventions. And what I offer is that this is a narrow definition of success, a definition of success that is based on a certain population, a convenient population, but not all Americans, not even close. Now, when we move into the phase of increasing inequalities, we have to understand that though we want to be able to decrease inequalities, these disparities persist. Because though we want to be in the phase of moving into reducing inequalities, we have a disproportionate lack of federally funded equity research to account for the phase before. So while we will have targeted specific innovation to adapt the status quo by disrupting these key flexible resources, which is a lot of what equity work does, we also reach stagnation points. And we reach stagnation points because we have systematic underfunding of equity work at the NIH. We have exclusion of Black and underrepresented minoritized researchers in the scientific space. we have misaligned incentives that do not actually incentivize us from the beginning to have inclusive trial design and to have equitable access to trials. And then we have, as the default, an exclusion of community input or minimal community input in designing trials. And so we can create endpoints like a certain amount of marginalized women that we want enrolled in trials without building the necessary infrastructure to actually bring them into the trial. Our default approach is not working. We have inappropriate low funding allocation, and this is so important at multiple levels. We know that we have underfunding of women's cancer research and women's health research that's been highlighted by multiple speakers today. But when we already are starting with such a low priority on women's health research, we are going to deprioritize the importance of marginalized women's health research and marginalized women's cancer research. We also have the systematic underfunding and exclusion of Black and underrepresented minoritized researchers. This article made the rounds and was followed with a secondary analysis that demonstrated that topic choice, specifically the topics of equity, of disparities, of community engagement, led to a lower rate of NIH awards among Black scientists. In addition, agnostic to race, overall, the categories that were least likely to be funded were those that were characterized by women's health, ovary, fertility, and reproductive sciences. Currently, our default system, it makes more sense for the very few Black and underrepresented minoritized cancer researchers to avoid women's health and disparities research than to engage in it. This is an example of the time to first R01 award according to underrepresented minoritized status and gender among scientists who had already received K awards, had already been deemed to be worthy and have high potential in NIH funding. And you can see there the discrepancy in time to reaching independent award status by both URM status and gender, with URM women at the bottom. This means that right now, in our current default system, the members of the group with the worst gynecologic cancer outcomes in our society, who are also NIH-funded researchers, are the least likely to be supported with independent NIH awards. We have systematic underfunding and exclusion of racism research. Racism operates at all levels across societal structures and environments. It also operates across the entire cancer control continuum, from prevention to screening to diagnosis to survivorship. There are multiple ways that these different upstream and downstream factors are going to influence the cancer control continuum. So we don't need one RFA on racism and cancer outcomes. We don't need one RFA on disparities and women's health. There should be as many opportunities, study sections, and RFAs for funding as there are potential connections between these upstream and downstream factors and the cancer care continuum. My question for us today is, how do we disrupt this process on behalf of improving the lives of all people with gynecologic cancers? If we understand that based on our societal structures, these are the phases we're going to move through, how can we use the infrastructure of the NIH, the resource of our investigative workforce, the untapped resource of community to disrupt this pattern? I want to present to you an idea or some ideas about an anti-racist approach to women's cancer research. First, we need to embrace cross-cutting approaches that acknowledge the power and complexities of how racism influences health. And I have some thoughts to probe our minds. Early detection in the setting of different social and physical environments. Clinical trial design in the setting of racist funding practices. If you have set up trials that are underfunded from the beginning, that are poorly funded, you are going to bias towards being able to have trial participants who are most easily captured, who are convenient to find. And by definition, you will bias against marginalized groups and underserved groups that find it more difficult to enroll on those trials. Treatment environment as a mediator of treatment completion. What does it mean? What environment are you in? Do you live in? Do you receive your care in? That might mediate whether or not you complete treatment. And also, I think this is really important. How do we think about and conceptualize survivorship when we have different values around life, Black life, and Black labor in this country? These are just 4 ideas. There are so many more between these connections, totally untread territory that we have access to as women's cancer researchers. We need to align our funding to incentivize the study of the unjust creation, dissemination, and delivery of cancer research knowledge. This article was looking at a similar question in public health and finding that in decades of public health literature, it was very rare for systemic racism even to be named as a potential cause or as something to study. And I offer to you, anything that we are not naming, we are not paying any attention to. We need to use disciplinary self-critique to disrupt our current pattern of colorblind innovation. How do we come to a point where a question of something so indelible to our society like race that operates at every level and structure can be completely left out of any study or completely left out of a proposal or given 2 lines of attention when we know it's operating all of the time? We need to prioritize equity research that's grounded in theories and frameworks that undergird race, gender, and health. Disparities, equity, science is a science. It has frameworks and theories and approaches just like all of our other biomedical spheres. And we must approach it with that respect and understand that proposals and research that are built on these theories and frameworks are more likely to be effective. This is just one example of an intersectional framework for research participation, dealing with the very question we always have: how do we enroll more minoritized or marginalized women, people onto clinical trials? And understanding that there's individual and interpersonal levels, team and institution levels, systems and structural norms, all of which need to be accounted for in order to reach the ultimate goal. And again, that's just one. We have this example from Dr. Jonathan Jackson of inclusion science and thinking about how do we think about clinical trial design and recruitment at multiple levels. Right now, we start with study design and randomization and ask ourselves, how can we recruit more minoritized populations or marginalized women? Where in reality, we need to start at the level of the structure of clinical trials. Where can they be open? How can they be opened? Who knows about them? Are they designed thinking about the perspective of the underrepresented group from the beginning, or is it an afterthought? Multiple layers of consideration with also differential layers of intervention and differential areas of expertise required for that intervention. Number 5, we need to embrace a goal of NIH-funded research as a tool to disrupt the default outcome of marginalized women as a secondary priority. We can redefine innovation in cancer research to be equity conscious. We can redefine this. So we cannot claim innovation when we're not claiming inclusion of historically and continuing underrepresented and underserved populations. We can redefine what high risk, high reward means, especially in cancer equity research. Community engagement, community support, and co-leadership are areas where we are active, but we have much more potential to have even more innovative and novel ideas that really stretch us beyond our status quo. We need to fund Black scientists. I refer you to the excellent article written by Dr. Stevens and a group of Black biomedical engineering faculty on this topic. It is compelling, it is complete, and it has very specific suggestions that the NIH and the NCI could incorporate tomorrow to improve the representation of Black scientists in our field. We also need to understand that there is no default human. There is no default person to which all of the rest of us are aberrancies. And this is important in equity research because there is a bias right now of including control groups or comparison groups when trying to advance the outcomes of a certain marginalized or underserved group. And I offer to you that when we do this, we collapse the variability and especially collapse the ability to find the resilience points, the strength points, along with the deficits of any given community. We need to invest more in within group differences and within group studies among marginalized populations. Finally, which has been said multiple times today, in many different ways, we need to fund not just cancer research, not just women's health research, but cancer equity research with more money. We need to divest from the scarcity myth. We need to increase the budgets. We need to think about funding equity research with the same level we think about the personalized medicine initiative, with the same level that we think about many other biomedical focused initiatives at the NIH. We cannot do this from an underrepresented standpoint, underfunded standpoint. So just to recap, I suggest that we recognize that our default structure of cancer research creates and exacerbates cancer inequities for marginalized women. I think that this is an extremely important perspective to take so that we understand moving forward that not just one change here or there is necessary, but a radical rethinking of how we approach our biomedical enterprise. We need to embrace cross-cutting approaches that acknowledge the power and complexities of how racism influence health and investigators. We need to align funding to incentivize the study of how we create cancer research knowledge so we don't continue in our same blind biases. We need to prioritize equity research that's grounded in theories of race, gender, and health. And truly, I think we absolutely have the opportunity to embrace a goal, not an ideal, but the goal of NIH-funded research as the tool to disrupt our default outcome, to disrupt the default pattern of marginalized women's health as a secondary priority. Finally, I took Dr. Temkin up on the suggestion of simply putting out some potential RFA solicitations for gynecologic cancer equity. How about quantitative and qualitative evaluation of bias and exclusion in biomedical research and cancer? How do these biases create? How do they become perpetuated? How can we dismantle them within research enterprises? Development of multi-level approaches to equitable representation of marginalized populations in cancer clinical trials, really understanding that it's not a single intervention at a single level that is going to change the needle here. Looking at the impact of structural and interpersonal racism on outcomes across the entire cancer continuum. Really thinking about life course approaches when we evaluate gynecologic cancer disparities. And I could speak for hours on this, but understanding that, especially for the areas that we see the largest disparities in cervical and endometrial cancer, in this country, these are the endpoint results of a lifetime of reproductive disparity differences. And incorporating that perspective is going to unlock a lot of new ideas and thoughts about how we can approach these inequitable outcomes. And then finally, interdisciplinary structural interventions to overcome expected inequity in clinical trial participation. We need to use the disciplines outside of the narrow biomedical research framework to actually counteract some of our societal structures that would bias towards exclusion. Thank you. Thank you very much, Dr. Timken, for inviting me to speak on this platform today. Thank you to the Office of Research on Women's Health and the National Institutes of Health.